And we are back again from Watany Ophthalmology Summit from Cairo, and we have Professor Dr. Ahmed Assaf, Professor of Ophthalmology in Ain Shams University, consultant of anterior segment and refractive surgery. Professor Assaf is going to talk to us today about indications that you encounter in your practice for IOL exchange and how you tackled it.
Hello, good morning, and with pleasure, I'm honored to be here in this interview. According to your question, there are several indications for IOL exchange, sometimes because of the wrong power of the lens, ametropia, or probably sometimes because the lens has been put in an abnormal or wrong position. For example, I see a lot of single-piece IOLs have been implanted in the sulcus because of complications that happen in the original surgery, like posterior capsule rupture, and probably the surgeon didn't have the backup lens of three-piece lens, so was obliged to implant the lens in the sulcus, which is, of course, is not a proper practice. So most of the cases that I've been seeing these days, that the lens is single piece has been implanted in the sulcus, and the patient suffers from UGH syndrome, uveitis, glaucoma, hypema for a long time, and probably sometimes cystoid macular edema. So we have to remove this lens and implant another lens, a three-piece. Sometimes we have to put it in the sulcus, or probably we have to implant this lens and fix to the sclera. Other causes of IOL exchange may be because of the abnormal lens capsule complex, decentration because of some sort of neuropathies that come after time, sometimes after the original surgery, and the lens capsule complex is decentered. Sometimes it's falling or dislocated in the posterior segment, and of course, this is another reason for the IOL exchange.
Okay, so every patient is a different situation. Do you have a preferred technique, or do you have any advice for young surgeons that you would like to tell us?
According to the situation, every eye has its own plan. If you have enough capsular support, so it would be a good idea to just remove the first lens and implant a three-piece lens in the sulcus. If you don't have enough support from the capsule, probably we might need to remove the whole capsule and implant the lens either to be fixed to the iris by iris sutures, or probably iris inclavation, posterior segment, retropupillary iris inclavation lens, or my preferred technique nowadays is to fix the IOL to the sclera. We have two major techniques. The glued IOL technique has been introduced or published by Amar Agrawal, and the other technique, the flange haptic technique of Yamani, which is my preferred technique in the meantime.
And in your experience, what's the learning curve for either techniques for young surgeons?
It's a little bit steep learning curve, and you need lot of fine instrumentations. But I think about 10 cases or maybe 15 cases, and the surgeon would master the technique. The issue with the technique that sometimes you encounter some decentration of the lens after fixation. So by the learning curve, you learn how to center the lens, how to trim some of the haptics in order to get a proper centration compared to your first few cases. And of course, you need a lot of instrumentations. Most important, the microforceps to hold the instrumentation, to hold the lens haptics inside the anterior chamber during fixation of the haptics to the sclera.
Okay, and under less fortunate surgical circumstance, what would you advise?
I advise we can go for the anterior chamber lens, for example. Okay, no problem with that.
Mm-hmm.
And
it has proved okay during.
Yes, no problem with that. And we can go, of course, with the iris inclavation retropupillary, which is a very flat learning curve. You don't have even to put it in a retropupillary. We can just implant the lens in the anterior chamber as it's originally designed for. So we have a lot of options. You don't have to make things harder on the surgeon. According to the experience, we can implant from either starting from the anterior chamber lens, which is the least learning curve or the flattest learning curve, followed by the anterior chamber implantation of the iris inclavation lens, retropupillary iris inclavation lens, sulcus fixation, just sulcus implantation of the lens and leave it.
Yeah,
if you have enough capsular rhexis and intact capsular rhexis, you can just optic capture the lens while implanting the lens in the sulcus. You can add more fixation by capturing the optic of the lens within the rhexis, or go for another technique of the intrascleral haptic fixation technique or the glued IOL. So I just arranging from easier to
the most difficult.
most difficult.
Our last question today is tell us about your challenging cataract extraction situations and how you get by.
Sometimes the cataract is very easy, and many times it's quite difficult because of the hard cataract. And the most difficult cases, the cases with the weak zonules. And I will present a case that almost half of the lens has been flopped through the weak zonules into the posterior segment of the eye under intact posterior capsule during phacoemulsification. So in this situation, you have the part of the nucleus has been entrapped between the posterior capsule and the anterior hyaloid face. This is one of the most difficult cases. So what to do in this situation? Either to do pars plana vitrectomy or try to retrieve those nucleus through the intact posterior capsule. Sometimes it's quite difficult.
That is very hard, and very interested to see it today. Thank you very much for your time, and this concludes our
Thank you very much. Thank you.